So welcome, everyone. This is Susan Henderson from Disability Rights, Education and Defense Fund. And thank you for joining us today on our COVID-19 questions and answers weekly meeting. Today, we're featuring TJ Hill, the Executive Director at the Disability Community Resource Center in Los Angeles. And TJ and DCRC have been involved in COVID-19 response from early in the pandemic, and especially working on issues of meeting the needs of disabled people who have other intersectional identities. So I'm gonna just go through a couple of introductory slides and then hand it over to TJ. So if you need interpretation into Spanish, this slide lets you know how to get that going. There's an icon for interpretation at the bottom of your screen, usually over on the right. You click on that and then choose your language, which would be Spanish in this instance. And Letitia's doing our interpretation today. We also have closed captioning by Natalie. Down at the bottom of your screen, you'll see a closed captioning icon. If you click on that, captions will appear at the bottom of your screen. And today we have ASL interpretation by Brandon. I have him pinned, so you should be able to see him. But if you can also pin him, that will make sure you'll see him at all times. You pin a video by clicking on their image of the person. So in this case, ASL interpreter, and the 3 dots, and then select pin video. When the slides are showing, like right now, but there won't be any slides after this, you can use the bar at the right side of the slide to make the slide smaller and Brandon bigger. Please keep your mics muted and your cameras off so we can make sure everybody can see the interpreter and see and hear TJ. And finally, we'll answer a few questions at the end of the presentation. So with that, I'm going to hand it over. I'm going to stop the slide sharing and hand it over to you, TJ.
Great, thank you so much. Good afternoon, everyone. It's nice to see everyone today, and I'm glad that folks are on. It looks like it's a small group, so I'm gonna kind of restructure my presentation a little bit and sort of give you a little bit of a background about DCRC and how we initially sort of responded to the pandemic, and specifically the topic that I wanted to talk about is sort of leveraging management best practices and how that really helped us connect to the intersectional community needs that we have in Los Angeles. And hopefully we can then have a little bit more time for the question and answer time. That's more of a discussion if that works for everyone. So to start off, pandemic. This was obviously a huge challenge for any nonprofit to sort of navigate through. But very, very early on, in actually late January, we first became aware at the center of the tremendous vulnerabilities in our community. Some of the first reported cases, or at that time, because there was no testing for the virus, some of the first reported cases were showing up in not only in Los Angeles, but specifically in the communities that we were serving. We had our first visit from, and I say visit in a sort of amusing way, but we had our first visit from LA County Public Health in the last week of January. And it was a very cryptic and kind of strange visit to get from, because we've, first of all, never had, at least as long as I've been at the center, a visit from our public health. And they were coming to us to disseminate information about this new virus that wasn't very well known, and specifically about some protective measures that we should consider, and starting some public education around that. Again, very, very little was known. There was nothing out of the CDC and the federal government at this point. It really was sort of our public health responding to what they were seeing was an emerging viral threat in our area. Uh, by February, so just a month later, and that was the third week of February, we received our second visit from public health, and this one had a markedly different feel to it. That was not the general sort of information that was shared with us previously, but rather very specific questions about the population that we serve, how people came in and out, what our specific, sanitation procedures were. And it felt markedly different. In that conversation with our health worker, I sort of squared with the health worker uh, and pointed out that this was unusual, to be having two visits from public health when we had never had them previously, and I was concerned because by this time we had reports of some of the members that we were serving who were coming down with an illness that or several different sort of illnesses that at the time was sort of described as a very bad flu. And but we had a sense that there was contagion really close, obviously, to us in our community. And so in that conversation with public health the second time, I was able to get out of them that they were actively tracing suspected cases of community members who had visited our center, who had come to our center. Um, so that changed our conversations, our sort of knowledge of what was happening, and so yeah, so that was like right after Valentine's Day. I'll never forget that. And then we in the coming weeks, there was obviously a lot more acknowledgement that there was a serious threat to our community in LA. We were now seeing many more reports of the suspected illness, and again, not getting much clarity from the CDC or the federal government, except knowing that this was indeed coronavirus, had been identified at that point. And so we started probably that last week of February going into March, figuring out what we were going to do. And there were two parts of that, which was starting this conversation sort of around management ideas. So one was, what do we do? Well, I'd say the first question initially that I had was, what do we do to protect our community? Because there were, like I said, we knew that folks in our community were clearly getting sick, were getting infected, and were getting sick, and they were getting very sick. And so we started talking about what it would look like to close our doors to the public. I very quickly kind of went through an analysis of like, well, what could we do without interacting with people in a physical sense? And and I would say within a week's time, that conversation very quickly turned to also an acknowledgement that the threat was so much in our community that it would also affect our workplace. And so I started making plans the first week of March to move to remote operations. Um, our staff started moving to um, staggered schedules at first to sort of transition out of the office. We had to react very, very quickly, and setting up, all of our phone lines and everything to be able to manage that out. So that took about a week's time. We fully converted to remote operations in 1 week, and um, and uh, so on that last day, when we had gone to remote operations, I was the last person to leave the office, sort of going down with the ship, so to speak. And so by that time, we were completely remote, and we were shifted very quickly to, okay, this is what we do to maintain our workplace and the safety in our workplace. But then very quickly understanding that we were in the epicenter of what was going to be a very problematic uh, health issue. I wouldn't say we even thought quite a pandemic at that point, but it was very clear to me um, by that second week of March that we had completely gone to remote operations, that the impacts in our community were very, very great. Um, by the third week of March, we got the report of our first member having contracted and getting sick, being hospitalized, and dying from COVID-19. Uh, so this is really early, right? These are some of the first cases in LA, um, and very, very quickly through um, March and April, May, really through June, we saw the most significant impacts in our community. Um, in total, we lost over 25 of our members to COVID-19, many, many more that became sick and had other health issues. We also had to respond to the outside issues related to COVID-19, and there's a lot of things that sort of revealed themselves. And so going back to the management technique things, what we did was a very rapid community needs assessments, and sort of did that on an ongoing basis. Uh, and the community needs assessments were, okay, so we know there's a virus. What do we do to protect people, to get as much resiliency in our community as possible? And so we started implementing and doing community education, particularly around our membership, and initially on what do you do what do you need to do to be safe. Um, and this again is all happening as we're hearing more and more cases, and particularly concerning with the hospitalizations, the really, very high rate of hospitalizations in our community. And these are folks with disabilities. But then as we started to drill down into what, the demographics of what this population really looked like, it was clear that it was intersectional identities across the board that were also being affected. So we saw the same rates of hospitalization and very high rates of mortality in the HIV/AIDS population, well before anyone in public health was even talking about that population. We saw also other folks who were immune suppressed, cancer treatment, other immune disorders. Those folks seeing very high rates of hospitalizations. And then we started to see the emerging uh, populations not only intersecting race and ethnicity, very, very high rates in the African American community initially, and then followed shortly after, I think, when most businesses had moved and the health orders had come down to move the majority of non-essential workers to remote operations, or laying them off, obviously. uh, then we saw a markedly high transmission rate in the Latinx population, and we could directly attribute that to folks that were essential workers and that were working in food production and food service, and grocery stores and all that. Uh, so we were seeing all these initial markers, and at the same time realized that public health was not, our local public health was sort of responding as much in crisis as they could, I think, and they were not tracking the demographics the same way that we were seeing them. So that's when we put into effect, as part of that community needs assessment. So we did our community needs assessment. We could see where these emerging needs were and where the vulnerabilities were greatest. And then what was it that we could do to help bridge that gap between the need and the resources. And so we started very early, approaching public health, our other government partners, to engage in conversations about what we were seeing on the ground. And initially, those conversations were very difficult to be had, because the structure for those partnerships weren't really in place. Um, and but we, kept at it, made sure that we were joining as many, public policy calls, um, as many conversations as we could be a part of. Um, and particularly when we were talking about, when there were any conversations about the disproportionate impact on different communities, that, and particularly, the early conversations were just on race and ethnicity. uh, and we made sure that we entered all of those conversations to put it in the context of, yes, these are populations we're seeing, but and the same thing with, age populations. A lot of the senior services and senior community issue, they were activated, but there really wasn't a discussion about why and who, again, were the most at risk. And so we would interject ourselves in those conversations as well, to try to put it in the context of disability. Um, so that's sort of what we did prophylactically, and that's probably not a really good description, because we were still reacting very much. But I saw that as very much the early work that was needed to be done to sort of activate us into then meeting the rest of those community needs. So the other thing that was really interesting about COVID-19, just from sort of um, a social justice, social service perspective, was that uh, there were a lot of truths that were made more apparent. So uh, along, with sort of the racial justice, social reckoning that was going on over the summer, um, across the United States. Um, that was one sort of layer, but on top of it, we were seeing a lot more truths sort of being revealed. And that, again, was focusing on the extreme needs in the disability community, and not thinking about the disability community, although, as an independent living center, we're a cross disability organization and we represent, folks of all disabilities. And we sort of, we've always, talked that talk. But in terms of really walking the walk to meet the needs of intersectional communities, one of the things that revealed itself very early on was that when we talked about the disability community, we weren't talking about one part of the disability community. We were talking about those intersectional marginalized communities that existed within our community, within the disability community, and that didn't historically have a voice, and that were historically underserved. We saw those communities suffering the most and experiencing the greatest loss. And so, as part of our sort of ongoing community needs assessments and how do we respond to that, we also had to have this our own sort of reckoning intersectional justice issues, and have our own reckoning internally, not only around conversations of race and ethnicity, which were really important, but just deeper into the concepts of how do we serve community, and and looking sort of at historically how we delivered service. During this time, the DCRC was also engaged in a very active strategic planning process, which every other nonprofit leader had cautioned me that I should, put that on hold. Don't do, long-term planning during a crisis. And I didn't listen to that advice, partly because I saw the crisis as being a real opportunity for us to um, because we were in a crisis, making those plans, those strategic plans, in a way that acknowledged what was happening now and then historically, and setting a plan for us to respond more realistically and more nimbly to ongoing community needs as they emerge. And that process during COVID-19 really helped us in terms of our response. So out of those emerging needs that I was talking about earlier, things that sort of revealed themselves were the tremendous food insecurity in our community. We always knew that food insecurity was a big issue in Los Angeles. Uh, but this was now something that was starting to happen in terms of conversations across the country. As you saw lines at food banks, I would always, in those conversations again with partners, when we were talking about, well, what is the need in the disability community, and I would reach out to those folks that were running food banks, and we started our own program of food distribution, and again try to leverage creatively with whatever resources we had. So one of the early sort of thoughts on that was our access paratransit services shut down. They couldn't transport folks during the pandemic initially. And so what do we do with our access paratransit while it's shut down? And it so one of the ideas that we had was, who is not showing up at the food lines and in the food banks? Um, and it was our population, of course, not only because of the multiple issues that the disability community traditionally has around, transportation and access, but there was this other layer of health needs, right, of folks that really needed to be maintain as much social distancing and isolation from the rest of the community as possible. And so, we had folks that were already low income, that were probably experiencing food insecurity before the pandemic, uh, now not even being able to access anything, any sort of services. So one of the quick ideas that we had was to use our access paratransit to do meal distributions, door to door meal distribution, both on a weekly basis, and then a daily basis rather throughout the week, but then also leveraging any other sort of food pantries and food delivery programs that we could leverage. And so that initially is one of the ways that we really got food into our communities, into our community, in a way to respond to COVID-19. Uh, so that was, there, and that's just the food issue was sort of one of the issues that really emerged. The other thing that emerged really early for us was an acknowledgement of how we were continuing to support the community during COVID, which was similar to what we're doing today, through online digital means. One of the other things that really emerged very quickly for us within the disability community was the great divide, the digital divide, and how that impacted particularly the intersectional communities of color that we were serving. And so again, in sort of responding to community needs, as we now started to get funding from public sources, um, quite a lot of funding for COVID-related response, community response. There were a lot of conversations about, how do you best use those dollars, and how, what do we need to do? I saw that digital divide as just as much as a lifeline as any other sort of direct COVID relief program that we could have offered. So we used a significant portion of our COVID community COVID relief funds to create a digital bridge project, where we acquired devices, Chromebooks, and then implemented a training program for folks to get those to community members most in need, and additionally get them low cost or no cost initially, or very ongoing low cost broadband access. And so that program also very, very popular and successful. But again, understanding that we are just trying to, we're just scraping the surface of the community needs out there. Um, so, so again, using stuff creatively and thinking, how do you respond? And then we start, moving down farther in the pandemic. There's we're maintaining all of these programs. Food distribution still and continues today, and our digital bridge project continues today. Um, uh, you, understanding, that these are ongoing needs. Uh, the when vaccinations became, well, I should start actually before vaccinations became a reality. We started our, because we had developed those partnerships now with public health very early, we started conversations with our public health partners about when vaccines become available, how are we going to get them to our community? Because our community is most at need. And so we, again, we're really trying to elevate the voice in both local, state, and national conversations over the tremendous losses and impacts that we were seeing in our service population, and why we needed to focus vaccination efforts on this population specifically. Uh, it was a difficult conversation to have because the CDC statistics at this point that was mirrored by the most public health statistics in the United States and in most states was really focused initially just on age. And so, of course, when you did the age analysis, the folks that were older were the folks that were seeing the highest hospitalizations and then death rate. Uh, we kept on trying to sort of get people to understand that it, yes, age was a part, but that also accounted for a high percentage of the disability population. And in fact, one of the sort of scary outliers of that was there was a lot of fear mongering in the media, I think, about you know uh, the threats to the general population. Oh my gosh, this could hit anyone, and there was those horrible uh, again, extremely rare, but horrible reports of young children getting sick and dying. And again, there wasn't that sort of other part of the conversation that no, we were talking about folks, majority of them, who had some other condition, which we identified as a disability, but they had some sort of other condition that made them vulnerable. And so even within those outlier groups among the age groups, we were trying to focus on, like, look, it's really this group. But that was really hard because the way that the health data was being collected didn't reflect our population or comorbidities. None of that was being tracked, and so it made it very difficult to have those conversations. But we intercepted or injected ourselves again very early in those conversations, particularly in the national conversations. At this point, reaching out to um, the what we well, at that point, reaching out as much as we could to the CDC before the election, the new administration, and talking to the transitional government. One of the things that the Biden administration had sort of quietly campaigned on was the desire to activate the federal government in COVID-19 vaccination relief, and not really having sort of a clear plan of what that would look like. But it, I don't know. We just did the analysis, and so uh, we I would say actually on inauguration day was my first um, uh, uh, email to FEMA to say that I suspected that there was going to be this new effort, that FEMA would somehow be involved, and that the disability community in Los Angeles very much wanted to be a part of this. Um, and as a result, we were part of the pilot program to reach underserved communities through FEMA and Cal OES uh, to do vaccination clinics to underserved communities. And so we hosted one of the first vaccination clinics that was run in collaboration with the federal government at our center, and targeting the most vulnerable, underserved folks in our community. And that got us, really mobilized into uh, doing language access and reaching out to folks that way. and again, thinking about how are we activating communities, and doing that work. During COVID, we really, leveraged all of those relationships that we were building with the community and trust that we were building, um, with folks, that had existed literally, across the street from us, some service providers that we really, we all sort of existed in our own silos, which is a really horrible sort of image to think about, but we did before. And then, but during COVID, we really came together with a lot of our intersectional communities, um, in a way that was, this is what we're doing. How can we also help you? And what are you doing? And just having these conversations. I remember before the clinic, our vaccination clinic, we ended up vaccinating over 500 people at our clinic. Um, uh, uh, and this is like, again, super early in the vaccination process, so it was great. Um, I remember going to Latinx markets and Asian markets, food markets, and you know, talking to the family that ran it, um, or at least the managers, and said, who do you know that needs to get vaccinated, and who to, and leaving flyers, physical flyers with people, thinking like, you'll help, you'll get the word out. And that worked, you know which was so odd, um, in thinking, but it worked. And so not only did we get folks from very marginalized intersectional communities to come to our clinic and to engage, to come to our clinic, but they continue to engage us, in conversations of community partners. So we saw things like on our social media, a lot more interaction. We during this time too, we'd very much upped our social media messaging. We put out multiple messages a day, on our social media, which is much higher clip than we had been before COVID. But we found that as many venues and as many opportunities to do the communications and to reach out to the community, the more interaction we had. Um, so that moved us sort of, vaccinations are starting. And then suddenly, because of all the work that we had done, and because of the engagement, and because of the reaching underserved communities, and by the way, for our vaccination clinic, um, uh, our rate of, our show rate is what they call it in the in the vaccination industry. Our show rate for appointments was 99.9%. We had one no show for a second vaccination. And we personally called that person and tried to get them to come. And because of sort of multiple issues and sort of focusing on that individual's mental health, they weren't able to come for that vaccination clinic. But when even in that, all of the partners that we had been working with at FEMA and the state were like, how did you get that many people to show up? Like we had a line of folks, that heard about a clinic and would wait to see if they could get a shot, at the end of the day, sort of thing. And I kept on telling people, don't waste your time. Don't get in line. We're not going to have any leftover shots. And indeed, at the end of the day, on our clinic, we only had one extra shot left over, and we ended up giving that to one of the health workers who was a vaccinator, who was unvaccinated. So it, our rate um, of really reaching to the community and getting and meeting that need was exceedingly high. And I think a lot of people questioned, how did you do that? And it was really because not only did we do as much one-on-one direct outreach as possible, to the point again of calling people and saying like, you have an appointment, and make sure that you're here, and you need transportation, and um, but but also during that time period, really building trust within the community. And so as we rolled out vaccinations countywide, we were very much involved in the planning for both the county and the state. And now those early sort of outreaches we had done with public health were formal partnerships. And so we became a formal partner with LA County Public Health, and received funding from them to do um, collaborative outreach to underserved communities because we had done it so well. And again, then to talk about sort of where those barriers are. And we developed in concert with the county some of the first programs that were like, if access paratransit was an issue getting to vaccination sites, because you go and they drop you off and then you don't have a ride. We piloted the idea very early. I think at Dodger Stadium was the first place that we piloted it, and then it became the standard across our county. Was to create for the drive-through sites, uh, basically um, access lanes for people with disabilities. So if people required some additional supports, that became a lane for them. But if they used access paratransit, or they were using even rideshare, we ended up expanding it to people that were using rideshare as well, so that that you wouldn't be running up money, waiting in a long line, that we could get those people in and out of vaccinations early. And so we really, again, became this trusted partner with the county. And I think all of that resulted from sort of our thought process around um, how, yeah, how do you think creatively, and how do we meet needs as they emerge and as they reveal themselves to us. And so that is my story. I know that's a lot, but I would really appreciate it if we could open it up to some questions and hopefully a little bit of conversation, if any of these things have got people thinking about how we do this, particularly in planning for the future. I mean, like I said, for us, this entire process, and it continues to be a learning process. I don't see that there will be an end necessarily to our community response around COVID-19, because if it's not COVID-19, it's the next community need. And so I really look at this as now part of an evolving way that we do the work in the community. And that's what I hope that folks really get from this, is that as a social service provider, it um, changes your concept of, first of all, what community is, who our community is, and how do you meet those needs ongoing.
So thank you, TJ. This is Susan. Um, yeah, I think that's really important to think about. What's the next? How do we prepare for the next event?
Yep.
We got a couple of questions ahead of time, so I'll start off the questions. One of them is, what forms do families of children who have disabilities have to address their needs with regards to access to the vaccines and more information and any other resources you have to offer? So if you have a child with a disability, I know that 12 to 15-year-olds can get them now, but I know families are anxious to get their younger children. So is DCRC preparing for that group of folks?
Yeah, so we've actually been very we've been very active in the public education. And so I put this part in sort of our education, and it's keeping people abreast of vaccination access, of when it is open to different groups. So we did that not just with the disability population in general, but then with age groups and the professions. I mean, we really, whenever, there was a group about, when it was their turn and why it was important for those groups and why they were prioritized in that order. Um, and so one of the things that we've been doing a lot over the age groups and children is well, first initially for the older children that were seen at, that were first getting access, we made sure that we were working and partnering as much with the regional centers that would have direct connections to families, and try to leverage as much of their communication networks and their networks, parent networks. Anyone that's sort of lived or worked in the special education realm knows that, like, the the network of special ed parents is like, the Underground Railroad in a way. It's like, if there's one resource, it's like then they all know where the resource is. And so we really, again, try to leverage those communication channels to get that out there. But we've also really had a focus and a conscious focus on, as these new age groups become eligible, is focusing again on who are we talking about that's going to be getting access. And so I just recently saw some of the CDC data that came out, I think yesterday, and about the 12 to 15-year-old, and they're like, wow, they're getting out there. They're really seeing their access. When you break down those statistics, it's very reflective of the first folks that were really pushing to get access. So we're talking about primarily white, um, uh, upper or middle upper class families that are getting their 12 to 15-year-olds vaccinated. And while that's great, and it's important that everyone get vaccinated, we really want to focus again on those underserved communities. And one of the areas that we're really looking at, and we've been doing this consciously through our messaging, is you know which is like subversive or subconscious messaging, is, as you present images of children being vaccinated, to make sure that we include images of children with disabilities, but also children of color. And that has an impact. And I know it sounds strange, but one of the programs that we talked about in trying to get impact into the Latino community was focusing on grandmothers, matriarchs, and uh, uh, Latina matriarchal families. So we focused a lot of messaging in that area, and that had like this huge impact, because if you had the matriarch of the family telling everyone else, that she wasn't going to cook for them unless they went and got their vaccine, that had a huge impact. And so we've really tried to, as we're looking at these new age groups coming available, it's how do you address those needs as a community need, and particularly as family units, because children necessarily are going to have to be brought by their parents. And so if you have parents who are distrustful or not fully educated about vaccinations or vaccination access, or if there's barriers there to the parents in any way, those barriers are going to exist for the children. And so we really have been thinking carefully about how do we continue to do that messaging in a way that's going to be most impactful to children, all children, and not just the children that we've initially been seeing getting vaccinated, but yeah, it's sort of a moving target, but it's definitely something that's on our radar. And we've done a lot to try to, again, through our general information, get stuff out there about why it's important for people with disabilities to get vaccinated.
So this is Susan again, one of the things you mentioned, and maybe calling DCRCs the answer, transportation, people who need transportation to sites, especially if they have kids with disabilities who they have mobility issues. Would DCRC be a place to call to find out how to do that?
Absolutely. So we've been helping people I mean, if people call us and they have a transportation need, we'll help them or organize free transportation to a vaccination site. And you know, oftentimes too, it's also sort of the layer of access to healthcare in general. And we've really looked at this as, you know, thinking in the long term again beyond COVID is for those populations that traditionally have had lack or low access to healthcare in general. How can we leverage this moment to underscore the importance of healthcare access, and if that's, you know, sure, through, you know, get your kid vaccinated and you get vaccinated, and we'll get your transportation there and we'll make this happen, is understanding that that health access is important for families, and we you know, I really view that as a sort of long-term planning, right, of building resiliency in the disability community. If we think about all of these issues as it's not just now, it's like, well, how do we leverage now to really build that resiliency going forward?
Thanks. So does that mean like if somebody contacts you now, you will help them into
Absolutely.
the future? Okay. So if anybody has a question, if I think the best way to do this, if you can, is to hit the wave your hand using the reactions, or if you just want to unmute yourself and ask a question, that's fine too. So I'll give somebody else a chance to ask a question. And if we don't hear anything, I did have one more that came in. Okay, I'll go ahead. Somebody said they heard that LA Unified is going to start hosting vaccine clinics. Do you know, but hasn't seen any details yet. Do you know where they can get that information?
Yeah, so that is it's all evolving. The school districts. So what we're hearing sort of across the board is yes, the school districts are going to start making them available. Some school districts have already providing vaccinations at some of their sites. The best way is to reach out to your local school, and they will let you know sort of within the district and close to you when and if they do have those sites set up. I'm not sure if I think LA Unified has a few sites that have gone live. I know that some of the other smaller school districts have definitely started vaccination clinics. What we expect, and this is sort of in our conversations ongoing, right, is so we're going to be in summer break soon, and there'll be a lot of school sites unused during those summer months. And how can we leverage with the county and folks, particularly sort of you know, those local elementary schools that are really you know, sort of peppered throughout communities and in underserved communities. How can we make those vaccination sites to really get people that you know, in their community? And that is a conversation where I think that we'll see probably over the summer as part of a real effort to hit those very underserved communities, we'll see these short-term, I won't call them pop-up because they'll be there for a while, but short-term vaccination clinics over the summer using the school sites. That's what I suspect will happen. But some of the school districts, some of the schools I know will be offering and have been offering vaccinations at some of their schools. So an example in Santa Monica Malibu Unified School District, they have 3 school sites that are designated to provide vaccinations on certain days. So they sort of they rotate out, but and they've been successful at getting particularly underserved and low income families and undocumented families getting folks vaccinated. So again, the strategy there, right, is how do we leverage trusted partners and trusted folks in the community. Schools are a great one, right? Because folks across the board have been getting access to a variety of services through their schools. And so if we can try to leverage those relationships to get more vaccines out there, I think that's a very good strategy.
Okay, so we have to start wrapping up. We need to give all of our interpreters and our captioners a break. Can you just share your DCRC is on Facebook and Twitter. What's your website and the best number to reach you?
Sure. So our website is, let me make sure I get this right, is www.dcrc.co. So it's co and not com. That's where everyone makes the mistake. And we've got our Facebook and Instagram and Twitter. Our handles on those are at DCRC by your side. And follow us on those. Again, we put a lot of content out on that. And finally, the good old-fashioned way, if you'd like to reach out to us, you can call us at 310-390-3611. And let's see, what else can I tell you? Well, and the good news is we are now fully reopened to the public. This has been another sort of surprise, but we've had about double the amount of people that we had pre-COVID coming into the office on a daily basis. And I suspect that's because of the great needs in the community, but folks are also welcome to come visit us in our Mar Vista location at 12901 Venice Boulevard in Los Angeles.
Okay, thank you so much, TJ. And thanks for everyone for joining us. We will be, we recorded this and it'll be up on our website, and I'll send out an announcement about that early next week. So everyone, you can share it on social media with us.
We definitely will.
Okay, thank you, Brandon and Letitia and Natalie. Take care, everybody.
Thank you. Bye.